I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness.
This is part of, as Lou said, 5 debates. We're going to have 2 today, 3 tomorrow. And the impetus to have the debates is that we often find ourselves in clinical practice in situations that don't lend themselves easily to black and white answers. And the relevance of this is large because it affects what we're ultimately doing with our patients. So we've picked 5 topics that we know there's a fair bit of, let's just say, lack of agreement, or there's lots of opinions in the area. And we're going to have debates, and I didn't realize until a month or 2 ago I'm doing all debates with all 5 of them. That's okay. So, in fact, we're going to start off, Steve and I, and we're going to debate the topic, does DSM-5 adequately capture depression with mixed features? Here's a case. I'll read it aloud. 16-year-old patient in a major depressive episode is also presenting with racing thoughts, irritability, and agitation. She does not meet the criteria for the DSM-5 mixed features specifier, which are at least, if not more than, 3 of the manic symptoms listed there. And you know them all. So this is someone who has depression, has what we would call elevation type symptoms, elevation meaning an increase in activity of thoughts. Her moods are agitated, and she's motorically, maybe psychomotorically agitated. Question for you. Does DSM-5 adequately capture depression with mixed features in your view? Yes, no? Okay, all right, that's pretty strong views there. Now, I should also mention that some of us are taking positions that we believe deep into our genome. Others, in fact, are asked to take positions that may not reflect what their genetics are telling their brain. So we will have, hopefully, some rapprochement towards the end. We'll see how this goes. So I've been asked to argue, yes, I guess that 16% or so, DSM-5 does adequately capture depression.
You're in a deep, deep hole, brother.
It's a deep hole. So let me, in fact, if I can, make the argument why DSM-5 really got it right. First, we know that the inter-rater, that is the inter-observer agreement for diagnosing bipolar disorder, is lousy. In fact, I showed you some numbers during my presentation, but the takeaway is that the flip of a coin is almost as good as seeing a clinician. So we need better ways of detecting bipolar disorder than relying on your gut. In other words, relying on your gut biome to make the diagnosis. So the DSM-5 has come along and said, we need empiricism. And so what they did is they said, we need specific symptoms. Not any symptoms, specific symptoms. So in that case, that person did not meet the criteria for DSM-5 mixed features because that person did not have the specific features. Why were they so rigid? Well, because you know that in a depressive episode, some people can have irritability. By definition, many people with mania can have irritability. So you didn't want to count that symptom twice. They said, okay, irritability is not going to count towards mixed features. We want items only that are specific to this phenotype. And the reason why 3 items was chosen is because 3 items turned out, when the biostatistician did the work, to separate the 2 groups robustly. That is, the groups with major depression and bipolar. So I happen to believe that relying on science than the gut biome is a better way to do business. That's why the DSM-5 came down from heaven. Steve.
All I can say about the DSM-5 adequately capturing it is, what? Guys in the back, you're going to use the clock so we can keep our time? This one? So, I would say that the argument is that it doesn't, because anybody who argues that it does leaves me baffled, bewildered, befuddled, and bemused. I am baffled why they would leave out the three most common symptoms, which would be psychomotor agitation, irritability, and distractibility. If you got those, they don't count. That case that you saw does not have mixed features according to DSM. I'm bewildered. Who am I going to give an antidepressant to? Because, as you know, that tall Canadian from the north, McIntyre, he wrote with the short Californian from the south some guidelines about how you actually treat, and mixed features don't get antidepressants. So I'm bewildered. I'm befuddled because is it old mixed DSM-4 where you have to be full mixed, full depression and full mania? Is it basically only be bipolar 2, which is what the so-called ICD says? Or can you have bipolar 2? Can you have rapid alternating? Can you have, I don't know, what if you're never manic? Can you have mixed features? Of course. So this whole thing just befuddles me. And finally, I'm bemused because the old mixed used to be depression mixed with anxiety. Now we're having depression mixed with mania. Bottom line, DSM-5 sucks.
Well, let me see if I can address that very...
They're eloquent. That was eloquent,
That was eloquent, eloquent, and very polarizing, which is appropriate. Very polarizing. Okay. Well, my view is the following. I happen to believe that the diagnostic criteria should not only have fidelity to the science, something that Steve obviously disavows, any of the science, but secondly, what I actually also believe is that the DSM-5 should reflect the natural habitat of mixed features. Not some contrived lab that Dr. Stahl likes to work in, but actually the natural habitat. I work in the natural habitat, not in the sanitized labs that Dr. Stahl works in. And in my world, the patients that I see, in fact, when they see investigators, they come in, they've got depression, and they've got mixed features that are both qualitatively mimicking what's in the DSM-5. And my experience has also been that when people have mixed features, they don't have the full Monty, they only have 3 or 4 symptoms. And so therefore, I happen to believe that the DSM-5, again, not only came down from heaven, but one of the, in fact, beautiful songs out of the DSM-5 is that they got that cut score at 3 items for mixed, which separates out major depression and bipolar. In other words, if you got more than 3, you start seeing very different organisms, and the items they chose were based on the best of science. I'll leave it there. It's obviously a very convincing argument that I've made. Nothing more to say.
So when I'm hunting bipolars in my habitat, and somebody comes into me and says, I've got racing thoughts and I've got, second symptom, and anything else? Oh, I've got sadness, but you got any more manic symptoms? No, give me a third, come on. Give me a third. I need a third, because if you don't have it, you're not. 2.0? Is that really how it works? So that person gets treated as what? Now, I will give you the possibility that when you conclude psychomotor agitation, irritability, and distractibility, you might actually not have a real mixed case of mania in the depressed patient. It could be anxiety. There is a such thing as anxious depression. It could be ADHD. So I don't really care about diagnoses. I want to know what is serotonin reuptake inhibitor responsive syndrome. And I want to know what is stimulant responsive syndrome and what is atypical antipsychotic responsive syndrome. And if a person, I would give you this, that has some symptoms of psychomotor agitation and distractibility and irritability, may not all be treated as mania. And so that's probably a decent part of DSM-5. But to leave those out entirely, I still have patients with those. What am I going to do with them? Am I going to treat them with reuptake inhibitors because they might be depressed? Okay, what if they don't respond? The DSM says they don't have mixed, so you have to keep on treating them as anxious depression. Well, maybe, you know, they're catching bipolar 2. So I have really much more a treatment perspective. I want to know what to treat them with. I want to, maybe I have to try, if they don't meet full criteria, maybe I have to try a reuptake inhibitor first. But then I'm probably not going to try 3. I'm going to probably then at that point say you have to go to an atypical.
Okay, sounds very strong, very strong. Maybe I should close with a couple of remarks, because obviously I have one, no point saying much more. So the closing remarks would be that, you know, I'll meet you halfway, Steve. I'll meet you halfway in this unipolar, bipolar continuum. I'll meet you right in that middle. I think, in fact, if we look at how persons with mania in real-world practice appear when they come to your clinics, that is, they have syndromal mania woven with some subsyndromal depression, anhedonia, suicidality, in many cases problems focusing, concentrating, that actually is not unreasonably captured in the DSM-5. I think where things go a little bit astray is where we spend 98% of our lives, that is on the depressive side. In other words, patients have full-blown depression. My experience has been what the DSM-5 is emphasizing is not what I'm actually seeing, and what I'm seeing is what this particular patient complains of. So I'll meet you halfway.
Okay. Well, I think it is important to make diagnoses because I want to get paid. Therefore, I'll meet you halfway. But as soon as I make the diagnosis, I deconstruct it into the specific symptoms of that given patient, and I'm trying to make people's symptoms go away. And I think that where we as a group in this room can make an impact on the field is to get this message out to our colleagues who are more in primary care and do more of the treatment than we do as mental health professionals. And what they may be doing if they don't realize that possibly somebody who has these secondary symptoms, they don't know it unless they look for them, and if they've got it, they may say, don't keep giving another frickin' SSRI, okay? And so maybe those people should get the news that some of the people that are out there that don't respond to SSRIs are because they have mixed features. Some are treatment-resistant unipolar, I got that. So don't keep on doing the same thing over and over again and expect a different result. So that's really the news, is to say, when things are not getting better, think and re-diagnose. Take a history. Sometimes it's really shameful, but how many times have you and I been in this road where you're treating a patient for 6 months and you've had 3 different drugs, and all of a sudden, at the start of the 7th month, it's like this revelation comes over you. You said, it's time to take a history.
Yeah, so it's true.
And then you go look for the manic symptoms. It's humbling, but we all do it. So taking another history can sometimes uncover these symptoms, and then you're switching from reuptake inhibitors to atypical antipsychotics.
You know, Steve, just during my presentation, one of the points that I pressed is that when a patient has a depressive episode, if they've got what I call the 4 A's, they're anxious, they're agitated, they're angry, they can't pay attention, that should really be the alert to you. They probably have mixed features. And what's interesting is that none of those A's count towards the DSM-5 mixed features. So that probably speaks to where my belief systems are as well. Let's go back to the question. Does DSM-5 adequately capture depression with mixed features, yes or no?
That 16% better not touch those keypads.
Okay. All right. I think we agree. I think that there's a consensus in the field that the DSM-5 really emphasized the puritanism around the science, if you will, but real-world mixed does not look like
Yeah, I think
what's
you
in
really
there.
said it well, which is that if you want to study mixed features, you probably want to make sure they really do have mixed features. They don't have ADHD and they don't have anxiety.
Right.
So you want to purify that. You want to do brain scans on them. You want to
That's
look at
right.
natural history. That's fine. But if you have to treat them, then all of a sudden it falls apart because there's going to be many people that don't meet that, which are going to be maybe uselessly treated with reuptake inhibitors, which are destined not to work for them. And that's wrong for those people. So it depends on whether you're really doing research or taking care of patients.
This podcast was brought to you by NEI Prescribe, a point-of-care app that facilitates medication selections with over 140 psychiatric drugs. With this tool, you can quickly identify medications that may fit your patient's needs. NEI Prescribe is available for download on iTunes or Android.